I would like to start with some acknowledgments because this project was a team effort. It definitely wasn't just myself. And I appreciate all the help, especially from Dr. Cleary, as well as my other collaborators at other institutions. So as we know, the emergency department is really complex. The patients that we see come from a variety of places. We don't get a chance to pick them. They arrive when they arrive. And to provide care that's culturally sensitive, that adapts to these patients' needs is challenging. Our patient population can range from uninsured to immigrants, minority populations, Medicaid populations, as well as transgender populations, among others. We also know from decades of research published years ago that inability to really adapt to the needs of these patients will lead to patient non-adherence as well as worse health outcomes. So prior research also supports that when residents or trainees are exposed to underserved populations, that this positively influences their ability to provide culturally, feel culturally competent and being able to adapt to the patient's needs. With residents, ACGME does say that they set professional standards that residents are supposed to meet in regards to professional values as well as interpersonal communication. And this basically means they are expecting residents to be compassionate and respectful in the care that they provide. However, there's very little practical guidance in how to best teach residents to achieve these milestones. So our objective was to explore emergency medicine resident experiences caring for patients that they see in these diverse clinical settings in which they work. So eligible participants are emergency medicine residents that work at multi-site training programs at the University of Michigan, Emory University, as well as University of Chicago. These programs have at least 3 clinical sites that include academic medical center, an underserved population or underserved hospital, as well as community hospital. And this provides them a diverse clinical exposure to patients from different patient populations, socioeconomic factors, medical complexity, as well as medical resources. And then residents across all eligible training years were, residents across all postgraduate training years were eligible. So we explored residents' experiences related to working at different clinical sites. And this could include their direct patient care or things that they observed. We developed a semi-structured interview guide to explore topics related to cultural identity, frustrating patient care experiences, strategies for identifying and caring for vulnerable populations, as well as residents' ability to communicate with and adapt to the needs of the diverse populations they see. Residents were interviewed by phone, and the interviews were audio taped, transcribed, and they were made anonymous, and those that participated received a $20 gift card. So typical to most qualitative projects, we had 2 initial authors that read through all of the transcripts. We developed codes, we developed themes. We did this independently, then we came together, developed a consensus. And then the second level was having 2 additional authors also read independently, so then we can discuss together and compare to ensure trustworthiness of the themes that we discovered. This is just a quick look at our demographics in Table 1, and we completed 24 interviews. So I'm just going to touch on a few of the themes for the sake of time. And for my purposes, I'm interested in the stories, and so that's what you're going to hear as my data. So this is an example of a resident describing their experience working in a community hospital. They're describing how they had two patients with similar heart failure presentations. One was white and affluent, and the other one was an African-American male that was of lower income.
Everyone was just so nice to him, getting him everything he wanted right away, then admitting him into the hospital pretty quickly. I don't know if it was because he was white, or if it was because he had money, or because he followed up with his appointments. An African American guy who had failed to follow up at a few of his appointments was like, "Hey, I'm sorry, but I went out and ate some fried chicken and a hot dog," and people labeled him as non-compliant right away. The quality of care that second patient received, the disparity between it was astounding. The first patient asked the nurse for a water and got it within 30 seconds, whereas the other guy was sitting there yelling from his bed for someone to get him something, and no one responds. The second guy maybe waited in the emergency department for over 4 or 5 hours waiting on a bed. That was just something that I saw, and it irked me a little bit in the ED.
So residents often describe that when they were working with patients that were different from them, if we labeled it based on the cultural identity, it just pushed them out of their comfort zone. When they had patients that were similar to them, it just made it easier because they were relatable, they felt like there was camaraderie with the patients that were similar to them, and that just made these situations where there was a difference more challenging. So we also tried to elicit why they thought there was what were the underlying reasons for why these situations were challenging. And the 3 or 4 major things that came up was it could be related to the social interaction or the behaviors that the patient demonstrated, value differences that they perceive, mistrust amongst the population, or something related to health literacy or language barriers.
I have had the most challenging encounters with the more low-income African American population because it's so different than the culture in which I was raised. I'm from a somewhat wealthy white background. My medical school was actually an urban safety net hospital, so I've been exposed to this population for several years now, and I'm definitely learning how to relate with them better, but I would say overall, they give the impression that when you're dealing with them, it seems less respectful, and a lot of time they seem less engaged in their health care.
So this is an example of how this resident perceived that there was just different social behaviors each time, or sort of in this generalization of the times they interacted with this minority population. This is another theme that came up related to the effect of these cultural differences on the actual care that's provided. Oftentimes, the main themes were it affected the time you actually spent with the patient, as well as the tests that were ordered.
A few different occasions, we're using an interpreter phone. I can only get so much of a history from the phone, so we have to, unfortunately, work somebody up a lot more than we would otherwise, despite having professional interpreter services. How do you differentiate chest pain that is a lot of the time based on history? Does it sound like GERD? Does it sound like angina? Does it sound exertional? What's the cardiac history? Patients just don't know that, and you're not going to get it talking through an interpreter. So unfortunately, a patient is getting a very extensive workup that they may or may not have needed, and that can be quite frustrating.
So I just want to wrap up and focus more on the influence of the residency program. And I want you guys to think of the residency program as the clinical environment that the residents train in, along with the people that they're working with and the curriculum. So overwhelmingly, the residents did feel that being engaged and working at these diverse clinical sites was helpful. It broadened their perspective. They were able to see unfamiliar cultures, get a sense of what parenting styles, different language was out there, different cultural practices that existed, as well as increase their confidence that they could work with a broader variety of patients. They also felt that it increased their marketability. So being able to work within these different hospital systems and working with these broad populations, they felt more informed when they were deciding what clinical setting to work in after residency. However, there was also a major theme that came up where there was a lot of frustration working in some of the underserved areas that made for a lot of residents, they noted how they were initially interested in working with these populations, and then as residency progressed, they were less interested. And this is just an example of the burden of work in these environments.
I think it was a difficult situation because the hospital that I'm at is so incredibly busy, it's busting at the seams with patients. The actual attendings who take care of the patients never have time to talk to the families. Because they see so many patients, seeing the patients takes 8 to 10 hours. There's no time left to talk to a group of 20 family members. The families feel like they're not being informed of what's going on. Understandably so, because they're not. Because the attending is not calling them, is not reaching out to them, because they don't have time to. I mean, they spend 8 hours on war grounds just to see the patients. I don't see that in other hospitals.
Residents also commented on the benefit of the makeup of the faculty program and the positive influence that had on shaping residency culture.
We have people with different sexual orientation, people with different ethnicities, black, white, a good amount of females versus males. We have people who are Muslim. That increases the odds of delivering good care because you just have a better understanding of what the patient may want to work with. As a physician, you want to hear from other people what their perspective is, just in case you're faced with a patient that might have a similarity to one of your physicians. They may say, they won't do this because of X, Y, and Z. Sometimes, if you don't have that supply or diverse experience, you can be missing out on the efficacy of your care, as well as the opportunity to send people from your program to serve a certain community.
But I also want to note that residents also describe the impact of curriculum on their ability to be able to provide culturally competent care.
As a patient became more alert and we had an opportunity to have a discussion about how they viewed gender and identity and what was their genetic sex and what was their gender identity, which are two distinctly different things, we were better able to care for the patient. We allowed them to essentially advocate for themselves and be more involved in their care. I feel like we recently had a lecture about how to navigate these scenarios. I felt prepared for this. You learn something in theory and then you actually have to use it. I feel like that scenario stands out in my head because I had to apply something that I just recently learned.
So this resident statement was only a handful of statements where residents could actually refer back to something they learned directly from their curriculum that helped to inform the way they practice medicine. Overall, most residents sort of referred to either a senior resident that they used as a role model or their faculty. There was not often any sort of reference to any deliberate curriculum related to cultural competency or communication. That's just a summary of some of the themes that emerged. I will note that even though we conducted these interviews over the phone, that I do expect that there was some social desirability where even simple questions of how do you define cultural identity, some residents, most of them, noted that it's how that person defines themselves, and in reality is how we define them, as well as often how the patient defines themselves. And so there was a reluctance to acknowledge that some of the way that we view our patients is based on our own personal views. I also think that, there might be some reluctance to say that this is generalizable. However, the intent wasn't for it to be generalizable. It was really to start exploring what are their stories, what are their experiences. There could be some selection bias. When you start talking about diversity, culture, there are some people that will raise their hand and volunteer for that and others that won't. And so we may not have a breadth of those opinions of people that are less reluctant to talk about issues like this. As well as there could be some coder bias. Although the transcripts were anonymous, one of the coders was very well-versed with the residents. And so even though the transcripts were anonymized, was able to still pick up on who was who. But that was at just one site. So in conclusion, emergency medicine residency programs should be preparing their residents to deal with the complex challenges of caring for diverse patient populations, because cultural differences between the medical provider and the patients is not uncommon, and it can be challenging. However, residents' confidence does seem to improve with exposure and familiarity with diverse populations. Therefore, gaining residents' perspective on their experiences can help to inform potential teaching and assessment strategies that can inform the development of novel educational approaches to enhance residents' communication and interpersonal skills.
Hey, Adrianne, I got a question for you.
Sure.
Awesome work. So poignant work. And I wonder if it'd be helpful if you could share what you feel like the strengths of qualitative methodologies are, where it may not be something that folks are really exposed to very often. And clearly this is, example of that.
So for me, if we even just look back at the Institute of Medicine report, which has been published 20 years ago, when issues come up now where there's concerns about which patients are getting the right care, whether patients are being, security is being called for one population in the ED more than others, I do think the stories help because the numbers have existed for decades. And I think, particularly for emergency medicine, what I hope with this project was that it would allow us to start a conversation based on real experiences, because there's a bar that's set that says we should be providing this type of care. And as part of trying to gather these stories, I wanted to have that context of how challenging is this in the emergency department, where you're seeing so many different people. You have to deal with the pace and the sort of multitasking. And it was, I thought it was just more helpful to start with actual stories, because, and you know, there's probably some reluctance on some part for some people to feel that this is a problem that exists. And I think it was something that Dr. Richardson remarked on earlier, in the sense of people might say, I give care, and some residents commented on that, I give care the same to each person. But you can't, because each patient may need something different depending on where they're coming from, what they understand of what you're telling them. And so I thought it could just be helpful just to hear stories so that I could share the stories, to be able to start a conversation that doesn't seem to actually happen, despite the fact that we know that there's an issue in regards to health disparities and communication and ability to adapt to patients. So hopefully the qualitative research can add to the data that already exists.
Thank you, Adrianne. I really applaud you, because it's very difficult to present qualitative work, and I think you did it very effectively by embedding the audio into your presentation, something I'm never brave enough to try, because something always goes wrong when I try to embed anything other than a couple of pictures in my presentations. But, and it really is very valuable. It's sort of starting with the why, going back to what Rob said, but where do you take this now? So now you have the stories. Hopefully you'll figure out how to get this published somewhere. What's the next step for you in this line of research? How do you go from starting the conversation to changing behaviors?
So part of getting the story was more so to introduce it, to say these are residents at 3 different sites, and these are their different experiences, and these are the themes across sites. Part of the project also asked them, how would you like to get feedback? What would be helpful in order for you to learn about this? And so there's additional data that sort of gives a sense of, from their perspective, this is what they would think would be more helpful than this sort of passive approach to teaching communication. And so hopefully that part of it allows educators to have something more tangible, not only to start talking about it, but to say, maybe we should try this here, whether it's intervention where you have someone develop an OSCE. Some of the programs did have sort of these standardized approaches of exposing the residents to clinical scenarios to challenge them, but they gave a variety of recommendations. So I think sort of organizing that portion of it will be the more concrete aspect to help educators develop educational curriculum.
Well, I think that's an obvious next step, and obviously you're focused on the educational aspects, but I would really encourage you to start conceptualizing how you take this work through to outcomes. You know, part of what I've realized in doing work on healthcare disparities is that they exist everywhere. I've never gone to a place where, when I asked, do you think you deliver equitable care to everyone, anybody who works in the emergency department said no. And then my next question is, do you have data to prove that? Have you looked at it? And every single practice that I'm aware of that has looked at it has found disparities, including my own. And so when I think it becomes really powerful is that these aren't just attitudes that people have and experiences that people are living through, but the way you perceive patients and communicate with them is affecting the way you deliver care and the outcomes patients have. And now that we have the richness of electronic health records where you can actually look at individual practice in ways that was impossible even 10 or 15 years ago. I really encourage you to start looking at the data and think about the conditions or the types of patients where you think this might matter, and as you develop educational interventions, see if they are actually having the impact that you want in terms of the way you deliver care. There are all kinds of interventions that can change behavior. I used to think that it really required everybody to have a lot of insight and sort of go through a personal epiphany to become culturally competent. And then I realized that was not a generalizable strategy, that I could not have every physician in America actually go through that experience. And so I started looking at ways that I could alter behavior without them perhaps even acknowledging and realizing the ways in which their impressions and the way they communicate was affecting outcomes. So think a few steps beyond the educational interventions to how we're actually going to make sure that whatever biases we bring, because we all have biases, that whatever biases we bring to the clinical encounter do not disadvantage our patient, because that's our responsibility as physicians. And I'd be happy to talk more about some of those sorts of interventions.
Okay.
So
Thank
keep
you.
up the good work.
Thank you.
Yeah, I just want to thank you again. The qualitative work is really interesting, and I think just, again, as Keith pointed out, is a way for people to think about. There's lots of ways to do research and get information on populations, and this type of qualitative work is really important, so thank you.